Hello, everyone, and welcome to our monthly chat for the month of April on high blood pressure, how and why we should do better. This is a disclaimer for our program this evening, and I would like to briefly introduce myself. My name is Alicia Chowdhury. I am the Outreach Director for the Brew and Beans Health Club, and I help facilitate these monthly chats along with the Brew and Beans Health Club and the Core Kidney Program at UCLA Health. Just to emphasize the pillars of the Core Kidney Program, we are based off of clinical excellence, outreach, research, and education. We do everything in our power to embody each of these four pillars in all the outreach events we do, as well as all of the care that we provide here at UCLA. Our core kidney program is built of the Circle of Core, which are a group of ambassadors that consist of people who have donated their kidney, people who have received their kidney, caregivers, and those related to increasing kidney health awareness internationally. We have ambassadors from everywhere working to help alleviate the limited kidney health awareness that there does seem to be existing and its prevalence, and we are working together through the Circle of Core to help increase awareness nationwide. The Bruin Beans Health Club is the undergraduate chapter of the Core Kidney Program at UCLA Health. We consist of a very limited number of undergraduate students that are working on many outreach, research, clinical, and more educational initiatives to help broaden kidney health awareness within the university level and beyond. April is a very important month, and I would like to highlight that it is also Organ Donation Month. And we have been spending our past academic year attending and hosting many outreach events to help increase kidney health awareness. And these are just a couple pictures from just a few of them from this past year. And they have been incredibly empowering for not only our patients, but their families and their caregivers. And we have been working very diligently towards this cause. Along with Organ Donation Month, it is actually also Fabry Disease Awareness Month. Fabry disease is one of the rarest diseases in relation to kidney disease, and this month is meant to for us to raise awareness, to support patients, and advocate for progress for our now Fabry Disease Awareness Month. Today's program is going to be hosted with Dr. Carolyn Kim and Dr. Sean Lay. Dr. Sean Lay is one of our newer core kidney faculty. He is a board certified physician in internal medicine, and he had earned his medical degree from Temple University in 2020 and continued on for his residency here at University of California, Irvine, actually. And then he completed his board certification and then his fellowship here in nephrology at UCLA. Today, actually, our newest faculty, newer than Dr. Kim, Dr. Lay, is Dr. Carolyn Kim, and she's a nephrologist who practices in Pasadena and Burbank. She enjoys practicing in all aspects of general nephrology with her special interest in hypertension, diabetic nephropathy, chronic kidney disease, preventative care, and transplant-related care. Hypertension will be especially important for today's webinar, so we're very grateful to hear from her expert perspective. I will now be passing it on to Dr. Kim and Dr. Sean Lay.
So my name is Dr. Carolyn Kim. I'm very excited to join all of you here today. I did also want to mention that I am in a UCLA clinic, and they have opened up a new clinic for primary and specialists in Pasadena. So it is within the confines near Huntington Hospital. So if you ever need to see a doctor or a specialist, we have a lot of availability and can probably accommodate you pretty quickly. So letting you know about that. And today's topic, I did want to talk about high blood pressure and why it's so important to monitor. And I wanted to start off with a story. And this is a patient, and I got his consent to talk about his case early this morning. And with the condition that, I mentioned that I am who I am today because of him. And this is actually a story about my father. So he back when I was starting medical school, we first got our blood pressure cuff as well as our stethoscope. And I was very excited to start using this. And so I sat my father down and we tried to measure his blood pressure. And so what would happen is we inflate the cuff as much as we can to stop the circulation in the arm. And then we listen with the stethoscope for the heartbeats that you normally hear. But for him, strangely, I wasn't able to hear the first and the second heart sounds. And, he didn't think much about it, and I didn't think much about it either until about maybe like a year or two later. We were in the emergency room and his blood pressure was over 200, and they were telling me, he has kidney failure. So he was started on dialysis from that day. And, you know, that's why I believe they do call it a silent killer, because he was, he didn't have any symptoms prior to this, till it was to the point of no return. But I am able to share this story quite happily because he got his kidney transplant last year. So this topic is very near and dear to my heart, and it's very, important to be aware about. So jumping in, what is high blood pressure? So the pressure is driven by the heart pumping. And if this pressure is too high, it can damage the organs by putting excessive, consistent, strain on the blood vessel walls. And then the blood vessel walls can eventually narrow, harden, and weaken over time. So this restricts the oxygen blood flow, and it causes the heart to work harder. And then this will eventually can lead to kidney disease, heart disease, and stroke. And so we'll talk more about the different primary and secondary causes about it in the coming slides. So what is systolic and diastolic pressure? So this top number, there's always two numbers that pop up when you take the blood pressure through the machine. The top number is called the systolic pressure, and it measures the maximum pressure in your artery walls when the heart beats or contracts. The diastolic pressure is the bottom number, and this is the lowest pressure in the arteries when the heart muscles relax between the heartbeats. And so, which one is more important? Both are very important to diagnose high blood pressure. But as we age and steadily over the age of 50, the top number becomes more important as the diastolic number stabilizes and sometimes gets lower. But the top number can go up due to the blood vessel stiffening, plaque buildup, or other different types of heart disease or blood vessel disease. So, a lot of older patients, we see that the top number is really high, but the bottom number is normal or lower. Okay. So the blood pressure categories, the American Heart Health Association, as well as the American College of Cardiology, updated their guidelines in 2025. And the categories remain the same as 2017. So it just focuses on earlier personalized interventions now. So normal is less than 120 over 80. Elevated blood pressure, we say, is in the 120 range. Stage 1 hypertension in orange is above the top number blood pressure of 130. Stage 2 hypertension, which is 140 or higher. And then the last two dark red and purple columns, it's higher than blood pressure 180 over 120, and this is when you want to definitely seek a medical professional. The difference between severe hypertension and the emergency part is if you're having additional symptoms of like chest pain, shortness of breath, back pain, numbness, weakness, or any vision changes or any neurological changes. So that's what they are. And high blood pressure can be diagnosed whenever you go to clinic, and they can then diagnose you with an average of a few readings, or you can measure this at home. And the ultimate goal is to be less than 130 over 80. So primary hypertension, so this is also referred to essential hypertension, and it's seen in up to 90 to 95% of all hypertension cases. And there is no specific etiology or known cause for it, but it's likely, due to a combination of genetic and environmental factors that in play affect the heart and the kidneys as well. So some risk factors we see here that have been associated with hypertension is advancing age. As we age, the arteries, as I mentioned, get stiffer. Race, with hypertension being more common and severe, and you see it earlier in the Black population. Family history may allude to some kind of genetic factors that lead to high blood pressure. And there's a lot of social, determinants of health, such as like low socioeconomic status, lack of health insurance, food, housing insecurity that could all lead to poor diet. And that could lead to high salt intake, which leads to increased water staying in the body. Otherwise, oh, sorry, that that also leads to obesity and lack of exercise. Other things not mentioned here are insufficient sleep, less than 7 hours in a day. So that has been actually shown to be associated with higher risk of hypertension as well. Things like caffeine, stress, anxiety all have a component in increasing blood pressure too. Secondary hypertension. So a number of common and uncommon medical conditions can lead to increased blood pressure. And many of these causes can coexist with risk factors for primary hypertension. So the major causes include a lot of medications, actually, like some birth control pills that include estrogen, a class of medication called NSAIDs, which include ibuprofen, Advil, Aleve, some antidepressants, steroid use, even illicit drugs like methamphetamine, cocaine can also increase blood pressure. And there's a lot of primary kidney diseases, which you would see in patients, possibly younger than 20 or older than 50. And many of these patients don't have a family history of hypertension. Another important cause of secondary hypertension is called obstructive sleep apnea. And this is the disordered breathing during sleep. And this has been shown to be an independent risk factor for hypertension as well. So as we can see in this pie chart, the diabetes and hypertension, high blood pressure make up a fairly large chunk of the leading causes of kidney failure in the US. So putting diabetes would be number one, high blood pressure number two, and all the other possibly kidney related causes and glomerular disease making up 7%, polycystic kidney disease at 1.6%. So why do we monitor blood pressure? Well, the ultimate goal is to see if you have high blood pressure or too low blood pressure, and does effectively give therapy for it to reduce any heart problems in the future or kidney problems. And it's very prevalent. So most adults in the US have uncontrolled blood pressure, and they were not taking any antihypertensive medications. And here's a few statistics here. Nearly 1 in 2 US adults, about 120 million people, have high blood pressure. Only 1 in 4 of those do not have it under control. And there's a lot of mortality deaths associated with high blood pressure, roughly about 1,800. So letting us know the very important reason to continue to monitor it. So the hypertension can be seen with different population groups. So gender-wise, you see it more in males versus the females. Racial, ethnic differences, it is more common, as I had mentioned, in the Black population, followed by the white males, followed by the Asian adults, followed by the Hispanic adults. And then among that, there was further study that found that the blood pressure control is best among the adult whites versus then the Black adults, then the non-Hispanic Asian, then the Hispanic adults. This is a graph of the US in 2025 by the CDC that showed that there is a higher prevalence of high blood pressure in the Southeast area. Um, it's interesting to see that we are not that red on this map, but still very important to take note of and monitor our blood pressures. So this was actually a research letter article published, I believe, this month of this year, so very recent. And they looked at patients between the years of 2021 all the way to 2023, and they found that a lot of people, 80% of individuals with hypertension had uncontrolled blood pressure. And in this group of uncontrolled blood pressure, 61% were not taking antihypertensive medication. And this just shows the discrepancy between the diagnosis and adequate treatment with lifestyle or medication. So barriers to success, uh, a lot of my patients do experience some side effects with various antihypertensive medications they have. So it's always important to discuss what you're experiencing and ask your physician if there's any alternatives for that. Finances could be an important reason that people are not taking their medications, especially if they don't have adequate insurance to cover the costs of that. Inertia on part of the healthcare provider. So this is a two-way street. It's very important for patients to come to our clinic to get a good quality assessment, but it is also important for the healthcare provider to give the appropriate therapy, initiate it or intensify it as needed. Other secondary causes include NSAID use, which are medications like ibuprofen, Aleve, Advil, which can increase blood pressure. I mentioned obstructive sleep apnea before and obesity as well. Lifestyle habits with those socioeconomic conditions that a lot of people experience, and then silent disease. So, I'll briefly talk about how to measure your blood pressure at home if you do have a monitor. So, it's, they say that it is more important to you'll get a more accurate reading if you take your blood pressure at home rather than at a clinic when you're already, stressed out about meeting a doctor and, nervous about it as well. So the best way to do it is keep yourself in a quiet room. No smoking, caffeine, or exercise about 30 minutes or more before you measure your blood pressure. Make sure you go to the bathroom, you have all your bowels emptied out, and then relax for about 5 minutes or more. You can then rest your forearm on the table at the level of your heart so that you're comfortable. And then during this period, we recommend that you definitely do not talk. You have your back supported against the chair, feet flat on the floor, and then you'll take a measurement. Wait a minute, a few minutes as you can, take another measurement, a third one if possible, and then you calculate the average by, each the top and the bottom separately. You take the top three numbers and then divide it by 3. It's best if you record your blood pressure, date and time, and repeat this as much as your doctor recommends for a reliable reading. And then you can bring that reading to the doctor as well as your monitor to make sure that the machine is accurate, that the blood pressure cuff is fitting you comfortably and not too small or too big, because that can definitely alter the reading. So how can I protect myself? What can I do? So we'll go over different lifestyle modifications, and I'm sure you know of most of them, but it's a good reminder to pay attention to these things that you can do. pharmacological agents, which are different medications that your doctors can take into consideration if you're still having blood pressure over 130 over 80, despite doing your best with lifestyle changes. So the lifestyle modification diet high recommended is to be high in vegetables, fruits, whole grains, white meat, fish, nuts, and low-fat dairy products. It's good to be rich in potassium, magnesium, calcium, protein, and fiber, and low in sweets, sugar-sweetened beverages, processed kinds of meat, foods, red meats, saturated fats, and foods high with total fat and cholesterol. It's important to limit your daily salt intake to no more than 1,500 milligrams of sodium a day. And yeah, always take a look at the nutrition label at the back of your boxes to see how much sodium there is so you can take into account how much you're eating in a day. Lifestyle modifications examples, physical exercise is, very, very important. Even just a walk 30 minutes a day is enough to help your blood circulation as well as, potentially decreasing your weight. And so weight loss is very effective as well. So every 1 pound you lose, your blood pressure actually drops by 1 as well. Limiting alcohol intake, 1 drink a day for women, 1 to 2 drinks per day for men. Stopping smoking is always recommended for your heart health as well as the health of all your vasculature, which is your arteries and your veins. And, smoking also can injure your kidneys as well. And then reducing stress, which is much easier said than done, but practicing activities like deep breathing, yoga, meditation, or regular relaxation. So, what should I do if my blood pressure still doesn't improve? Um, it's very important to monitor your blood pressure daily, or however much your doctor recommends. Start with the simple lifestyle changes and habits to improve your blood pressure with weight loss and diet and exercise. But I think the main thing, if you do have high blood pressure, is to go see your physician and see what trial of medication can be done to decrease it if it is still high, if your blood pressure is still high.
Thank you so much for sharing. That was very in-depth. And I believe we do have a few questions in the chat. Can you please share what is the easiest way for a patient to get their blood pressure tested?
Easiest way. If you do not have a blood pressure cuff at home, perhaps you can always purchase it, the automated machine at CVS. I believe the cheapest may be around $20. If you ask your doctor to prescribe it, maybe they can, send a prescription for it and see if your insurance company can cover part of it. I know in front of Walmart, CVS, they do have the blood pressure machines, so you can go and see if you can get tested there as well.
Okay, thank you so much. Can you tell us a bit more about white coat hypertension?
Oh, definitely. Yeah. White coat hypertension. So that is basically you see a white coat and you have a lot of anxiety, nervousness, stress, and your blood pressure shoots up. It can be over 130 over 80. But then when you go back home, your blood pressure is normal, less than 120, less than 130. So that is white coat hypertension, and that is um, not necessarily a diagnosis we give medication for.
Okay. And I think there has been some confusion about the preference between a manual or automatic blood pressure machine. What do you think there's a difference in the readings? Is one preferred over the other?
Manual, manual, is it, Dr. Lay, correct me if I'm wrong, but do you need someone else to do a manual?
Oh
Um,
yeah.
yeah.
To answer that question, the manual and automatic in the majority, the clinic that we use are currently automatic blood pressure machines. The differentiation that the process of measuring blood pressure through the physics or how to determine systolic and diastolic is determined by a machine that will be automatic blood pressure. When we're using a manual, is we use a stethoscope and listen for that sound that denotes systolic and diastolic, but that's taken care of by the machine. In terms of which one is better or the other, I think the more important is convenience and reliability. An automatic blood pressure machine has been shown to be more consistent and more reliable, and there's no interpersonal variability, meaning one provider or one individual might read it differently than the other, as the machine will read it consistently through its own criteria and cutoff. So for my patient, and then this is the same reason why we use it in the clinic, is that automatic will be the easier of the two, but also it can use it easily at home, monitor it pretty consistently, and we can use these numbers to compare and contrast. Now, the important thing is not all blood pressure machines are made equal. Some of them are off by a little bit, and some can be off by a big margin. And that's why sometimes we tell our patient if you do get an automatic blood pressure, and sometimes we do see your blood pressure reading to be drastic between clinic and in home, sometimes bring your automatic blood pressure machine to our clinic so we can check it in between to see is the two machine pretty consistent result, and sometimes we have to calibrate the machine to match the gold standard or the standard that we use in the clinic. That being said, it can also be done at local pharmacy and CVS. You can bring your blood pressure to there as well, and to help you to calibrate and double check is the machine you purchased accurate.
Thank you so much, Dr. Shanley. We have a couple questions in the chat. A patient has reached out saying that they're a current high school senior with lupus nephritis stage 4. They're asking, what is the mortality rate as a present day of someone having a quality of life with what's as someone with this type of disease?
Oh, I can answer it. Regarding lupus nephritis, unfortunately, it is a serious disease. It is an autoimmune disease. Unfortunately, patients can develop autoimmune diseases of different complexity and different variety, and as a result, lupus nephritis is a serious diagnosis. That being said, lupus nephritis, once diagnosed, is a spectrum disease. Some patients have a milder form of it, and some patients have a severe form of it. The severe form, unfortunately, can cause kidney damages, and sometimes so severe and patient may end up in irreversible damage and even end up on dialysis. To talk specifically about mortality, I think that's be very difficult to talk about in the present day. As a study talk about mortality for patient with lupus nephritis, I think it's overall talking about lupus. But at the end of the day, I really just look at it how the patients are and what their kidney function is. If they had a milder form, of course, their quality of life and their expectations and their mortality would be much, much better than those individuals who has more severe kidney diseases in so forth require medication or even consideration for dialysis in the future. But overall, I think when kidney function declines, especially requiring medication, frequent lab visits, imaging visits, that takes a toll in terms of patients. Regardless of lupus nephritis or any other kidney diseases, it does take a toll uh, and need time to be evaluated for.
That being said, I think a lot of kidney diseases can sometimes be genetic, but has it been shown that high blood pressure can be genetic?
Yeah, there's been interesting studies about genetics diseases. So the reason I say to talk about hypertension, majority of the hypertension you might find out during a doctor visit is called essential hypertension or idiopathic hypertension. It means that unfortunately hypertension occurs with aging, and we may not know a rhyme or a reason why it happens, hence we name it essential. The other causes of secondary hypertension is that it's in addition to essential, there's something else going on that causes you to have high blood pressures. Now, it could be a genetic disease, or could be something else. A genetic disease that causes you to have irregular amount of hormones that stimulates you to have high blood pressure, that is possible. There are also genetic diseases affecting the kidney, causing excessive amount of sodium reabsorption. And when you have so much salt in your body, it causes fluid to be retained and it pressurizes the system and cause you to have high blood pressure. But to answer your question, yes, there are genetic diseases that causes you to have hypertension. And sometimes if we're able to find so, we can give you more directed treatment to treat the cause, in addition to treat the symptoms, which is high blood pressure.
Hmm. So a lot of the times, even as someone is aging, it might be unclear the specific reason why they might develop high blood pressure. So a patient did ask in the same vein that is it really realistic to expect a 60-plus-year-old to have the blood pressure reading of, let's say, a 20-year-old when there are a lot of physiological changes that happen within the vasculature and aging as well? What would be a normal blood pressure for them to have at that age?
Yeah, that's a great question. So I think it becomes a balance between the benefit and the risk. So let's talk about the risk of what we worry about. Um, the risk of aggressively controlling your blood pressure is more likely due to low blood pressure, meaning you can have dizziness and lightheadedness. And what we're always afraid of is when patients have a fall, they can really seriously injure themselves, either bone fractures or hitting their head and cause a brain bleed. So it becomes really a balance about how much can we provide without affecting side effects, and becomes a risk and benefit. To answer your question, it'd be difficult to try to mimic a blood pressure when we're much healthier. You may find out kids, or I shouldn't say kids, young adults, I apologize to the audience out there, their blood pressure might be much lower, in the low hundreds and 110s. And as we age, the blood pressure gradually gets higher and higher. To realistically pursue or to return a blood pressure in the low hundreds on 110, I think it's very difficult. Some of my population of patients can achieve it naturally. That's very good of them. And sometimes I don't think it's a realistic goal to do so. In those cases, we try to see what is the disease entity and their comorbidities. Patients with kidney diseases, we try to decrease the systolic blood pressure to less than 100, 130 as tolerated. In other disease entities, and if you're young, we try to even be more aggressive to 120s. And sometimes other heart conditions, especially in patients whose heart is not working so well, the cardiologist might pursue even a further goal, more aggressive than the kidneys side.
Okay. Um, I believe we've had a lot of attendees on this webinar today that have experienced high blood pressure and that has been out of control despite the usage of medication and lifestyle changes. Um, as a physician, how would you approach treating that as they have been trying to fix their lifestyle and have pursued blood pressure medication as well, and they're still persistingly high blood pressure?
Yeah, that's a great question. So I think a lot of my patients do not want to be on medications, and I agree. And personally, for me, even taking medication for myself is always a thing I have to constantly remind myself. So I can definitely understand, can I get away or can I get better by myself without medications? And I think that's what we try to do when patients come into my clinic when they have high blood pressures. We always give a trial of what we call conservative or non-pharmacological, which is really talking about dietary and lifestyle modifications only if it's safe to do so. If your blood pressure is causing you issues, I think we should do the conservative, but also start you on a safe and gentle and low dose pharmacological medications and see how we do. When we start a medication, if things do get better, it's not a commitment for life. We can always try to wing off medication and see how we do. But generally, we do try to give a trial of conservative management. And that being said, it's what Dr. Kim talked about, dietary changes, exercise, weight loss, and often there's sleep apnea as a thing as well when we age, and finding these factors that we can reverse and change. Small changes of weight loss, low sodium may not produce a significant amount, but when you add up these effects, it could produce a significant effect.
Okay. And why sodium specifically? What about a sodium intake within someone's blood results in such a high blood pressure?
Yeah, that's a great question. So sodium is one of the key electrolytes. We need to have sodium, and we can't have too little or we will run into issues, but we often can't have too much. When sodium is in our body, often is what goes in must comes out. So when we eat our sodium, majority, about 99% of sodium will be removed naturally through our kidneys. When patients have kidney diseases, when that ability to remove sodium is not as robust, so it takes more time to remove sodium. And number two, when we have a lot of salt or at one time from our meals or from eating out, that can really shoot up our blood pressure. And the easy way I think about it is salt and water are really best friend. Salt will attract water to remain in your vessels, and that can expand your vessels and pressurize the system and cause high blood pressure. And that's why we always recommend our patient to have a low sodium diet, which is less than 2,000 milligrams once a day, or less than a teaspoon a day.
Okay. I think a lot of patients express high blood pressure before they have manifested with kidney disease, with that's lifestyle induced. How do you, as a physician, approach a patient that has chronic kidney disease, like a chronic condition like diabetes or kidney disease, and let's say they have that and high blood pressure versus someone who just has high blood pressure? Does your approach as a physician change?
Yeah, it does. Specifically, I think it's when patients have kidney diseases, hypertension can cause kidney disease, but unfortunately, when your kidney function declines, it can feed back and cause hypertension and goes into this loop of negative cycle in which hypertension causes kidney disease causes hypertension, and just gets worse and worse. And you have to intervene with blood pressure medication to stop this negative loop. That being said, uh, medications. So for a specific population, especially a patient with diabetes, patients might know that diabetes is a slow chronic disease that causes microscopic changes throughout the body, including kidneys. And one of the few specific microscopic changes to the kidney can be directly cause protein leakages in the kidney. Protein leakages by itself over time can also cause kidney diseases. So in patients who have high blood pressure, there are agents or class of medication that lowers blood pressure, but also can lower the protein in the urine. So as long as the patient is able to be safely started and be monitored, we try to use a specific class of medication in patient with diabetes with protein in the urine, try to help one, lower the blood pressure, but also lower the protein using I would say, one stone, two bird approach.
And what are some side effects of these blood pressure medications that are so widely prescribed?
Yeah. So I think it really generally all blood pressure medication can cause have low blood pressures. So what we're afraid of, and when you don't have enough blood pressure in the system, what happens is when you get up really fast, your body responds by forcing the blood pressure a little bit higher so it can pump against gravity and make sure there's enough blood to the brain. If you don't have enough blood flow to the brain, you might feel dizzy, you might feel lightheaded, and sometimes people have a little bit transient changes in vision, and sometimes even more serious, they can faint or pass out. So these are side effects that we always warn a patient when they have low blood pressure, or sorry, when they're taking blood pressures. It's true for almost all blood pressure medications. That being said, other medication can have different side effects. Some medication, when you take it, can cause you to have laboratory abnormalities. And when we start patients, often you might hear us, we want to double check your kidneys or double check your lab a number of weeks after starting these medications just to make sure you don't develop these side effects. If so, if they're easily reversible by stopping the medication or decreasing the dosages.
Okay. And I feel as a lot of these patients have expressed having high blood pressure for a very long time now.
Mhm.
So, what blood pressure for someone who has hypertension indicates that they should go to the emergency room if they're used to seeing high numbers already? When should they
Yeah,
go?
so that's a great question. So often um, we often try to think about emergency room as, are we having really bad symptoms? Are we really having symptoms from the blood pressure that we need to immediate control? And that's the things we can do in outpatient setting are slow and over in time. So in those cases, we recommend a patient to go to emergency room if they develop symptoms directly related to hypertension. There are agents through the IV that can give a immediate and controlled reduction in your blood pressure. But if you're really having high blood pressure and not feeling symptoms, I think it becomes a question that I think you should definitely speak with your doctor to determine, do we need to go to an emergency room or do we not need to go to the emergency room? But sometimes I hear the cases if your blood pressure is greater than 180, you're not getting controlled, going to an emergency room to get checked out is not a bad idea. But often I try to relieve my patient of the burden, but talking with your primary care doctor if you haven't seen a kidney doctor would be the first step.
Okay. And let's say you do meet your nephrologist, at one point or another. What would you emphasize patients to ask at their either regular doctor visits or when they're meeting their nephrologist regarding maybe their high blood pressure?
Yeah, that's a great question. So I think always what we think about is how long have you had blood pressure and what are the numbers look like? And of course, to have those information, you should have a log of your blood pressures. That means you're taking your blood pressure, written down a number, and often try to take your blood pressure at a consistent same time. Trying to take it when you relax with proper techniques and bring those numbers to the doctor's visit so we can interpret the numbers. Sometimes your blood pressure will fluctuate throughout the day for unknown reasons. Sometimes it'll be on the high side, sometimes it'll be on the low side. But these are fluctuations throughout the day, and what we're looking at is a consistent trend that we can see. It sometimes it be in the 130, sometimes it be in the 140s, and that information is helpful to us to see how long have you been living at that range and how much do we need to prescribe to try to lower the medication. And of course, once we start medication, we need to see the response to medication, which is additional blood pressure monitoring. So overall, I think it's important to know how what your blood pressure reading is, how long you had it, what medication are you on, or what have you tried in the past, and what were the effects with these medications, specific side effects if you had developed any, and of course, other medication you take. As you may know, as a nephrologist from previous conversation, we always tell our patient try not to take NSAIDs such as ibuprofen, Motrin, Aleve, Advil, etc., naproxen. These are already available over-the-counter potent painkillers, but unfortunately causes kidney disease and causes hypertension. And if you were to stop these medications, your hypertension may just self-resolve on itself.
Okay. I know both of you have mentioned that it's really important to take your blood pressure at a good time when you're calm, when you're not having caffeine, when you're not exercising immediately before or after. But have you seen how like mental health might affect something maybe you can't control, like anxiety, stress, depression? Does that manifest within a blood pressure reading?
Oh, it will. Similarly to what white coat hypertension is that in is when you see a doctor, for unknown reason, albeit you're calm, you're subconsciously anxious, and that subconscious anxiety causes hormonal release and elevates your blood pressure. And if you were to go home living at a relaxed pace and you measure your blood pressure is much better. Similarly, that anxiety, when it's subconscious, we often will see the blood pressure to be much elevated. And what I tell my patient is try to relax. When you measure your blood pressure, I don't want you to think about anything. Take some nice deep breathers, nice deep breath, sorry, calming exercises. And before you even wrap on the blood pressure, your mentality or your mental should be relaxed. And when you put on the blood pressure machine and you start the machine, don't look at the numbers. It's going to cause you to have more anxiety. Just close your eye and let the machine do it itself. And once it's completed, take a look at the number. If it's elevated, wait just a couple more minutes, do some deep breathing exercise, make sure you're as relaxed as possible, and repeat again. And always write down your lowest blood pressure because that's your resting blood pressure. The elevated ones are probably just because of anxiety.
Okay. And to pivot a little bit, can you tell us a bit more about postural hypotension?
Yeah, postural hypertension is a specific, to break it up, is posture and then hypertension. So postural hypertension occurs when patients are changing with positions and they have developed hypertension when they're standing up or laying flat. So it becomes more of a nuance in terms of discussion when the hypertension happens. But ultimately, is we notice these in which patients do specific actions that elicit a hypertension response. Do they have hypertension? Yes, they do have hypertension. As the way we measure or determine hypertension is when they're relaxed, and if they're in a resting state and their blood pressure is elevated, they still have hypertension and needs treatment.
Okay. Is there a treatment that goes for patients that have expressed postural hypotension when maybe when they're only relaxed, they have a normal blood pressure, and then, when they're maybe standing up, going on their day-to-day life, they have a high blood pressure, but maybe it's not triggered by poor lifestyle or diet, etc. Is that still going to require a medication intervention?
Yes, it still require medication intervention, but the dosage will be much more different, and it becomes more of a lot more data gathering, and then trying of medications, and really just how to be careful because if the blood pressure is too low when you're resting, it can cause low blood pressure side effect. So in those cases, it's a very slow titration of medication to find a zone in which we're not risking high blood pressure, but we're also not risking the side effects of low blood pressure.
Okay. We have a patient sharing that they have high blood pressure, and when they visited Mexico City, their blood pressure raises because they were told by their family that it is because of the high elevation in Mexico City. And their family had recommended sea level areas for people with high blood pressure. Is this true? Have you seen this in your patients of your own, or are there research studies that prove this?
Uh, I have not. I'm trying to think about a physiological response that can cause you to have difference in elevation. Um, it is true when you increasing elevation, when patients don't have a long, when they are not getting enough oxygen, your blood pressure will get elevated, and increasing elevation will decrease your the overall oxygen. But usually, when patients are in normal health or normal cardiac and lung health, that should not be a factor. But I do not know the answer, and I had to do a little bit more digging to see in a normal population, does elevation will cause or attribute you to have hypertension more easily? Yeah, I have to look into that.
Okay. And regarding pharmacological intervention, are there forms of medication that you recommend versus another? Maybe versus like another nephrologist or one that is more readily prescribed, do you think?
Yeah, so I think blood pressure medications have been on the market for many, many years, and their side effect profile has been well studied. In addition to that, there's still new medication that comes on the market. That being said, the decision from one medication to another or is really patient oriented and disease oriented. Why do I say so? For disease, some disease will have better benefit and effect for the long-term health with this specific line of medications. If that's not the case, I think about patient-centric effect. Some medications once a day, some medication twice a day, some medication 3 times a day, some medication cause you to pee a lot more. So some of my patient tells me I only want to take one pill and one pill a day. So I had to find a medication that lasts about 24 hours so we can use that medication for more adherence. Some of the medication that takes 3 times a day, I feel that's a little bit difficult to fill out adherence bias. That means when you go to bed, you got to take your medication. 8 hours after when you wake up, you got to take a medication. Sometimes we do have to use it when the blood pressure is very difficult to use, but we try to stay away from that just for making it easier for the patient and make sure that they're able to follow through with our recommendations and medication prescriptions. Sometimes we recommend our patient to start with one line of medication that can make them pee more. Sometimes my patient tells me, I don't want to, but if that's the case, we take that into consideration so we don't have to worry about that for them. So there are a lot of thought process. Unfortunately, we do have a lot of different agents available on the market that we're trying to find one that's patient oriented and disease focused for our patients.
Thank you so much, Dr. Lay. We have another patient anecdote. I'm an 83-year-old female. I keep fairly active, and I don't have many serious health issues, but I did have a kidney removed due to cancer in 2024. My question is, how do I keep my single kidney healthy?
Yeah, that's a great question. So generally, we can live with one kidneys, and we just have to be very cautious as we don't have more reserve. We don't have another kidney in case of a rainy day. In those cases, I just tell my patient it's the same mindset that I treat with patient with 2 kidneys. Anything that can affect the kidneys, try to avoid them. And more particularly is avoiding the medications or avoiding things that can harm the kidney. I love to say is try to avoid NSAIDs or ibuprofen, especially when you have a single kidney, the effect is more profound. So try to really stay away from these over-the-counter medications that can really harm your kidneys. Number two is similarly to other illnesses, hypertension. Long-term hypertension can cause kidney diseases, and it will do so more frequently in patients with singular kidney. So likewise with patient with diabetes. So follow up with your primary care doctor if you haven't seen a kidney doctor, just making sure your blood pressure is good, your A1C or your marker of diabetes well controlled. Review medication to make sure there's no medication that is considered nephrotoxic or damaging to the kidneys.
Okay. And another patient has inquired, What are the statistics of untreated hypertension and the development of clear cell carcinoma within the kidneys? Is there a correlation between the two?
Uh, I think unfortunately there is no correlation with study that has been done. I think unfortunately we've seen cases anecdotally of patient with normal blood pressure developing renal cell carcinoma and a patient with high blood pressure developing renal cell carcinoma. So I don't think there is any available data that can correlate these two findings.
Okay. A lot of the time, patients have experienced anti-rejection drugs, and sometimes they have resulted in making their kidneys less effective year after year. And this may manifest with changes in blood pressure as well. Do you have any suggestions from a physician perspective on this take?
Yeah, that's a great question. We often see it. A lot of our patients are transplant patient, whether kidney transplant or non-kidney transplant, and often they have to take medication to avoid rejections, to preserve or to protect what their transplant organ is. And unfortunately, these medication can have side effect, and some of these medication can cause kidney injuries when taking for many, many years. And to prevent it, we often tell our colleagues, if they can, is to try to aim for the lower ranges of their therapeutic target. So they still get the effect of protecting their organ from rejection, but they have less of the dosage in the body affecting the kidneys. That's one thing. Similarly, when we do develop kidney diseases in patients receiving transplant and they are developing hypertension, we are similar to patient without transplant, we just have to intervene and treat the blood pressure, as hypertension can cause kidney diseases and kidney disease can unfortunately worsen the hypertension.
Okay. And can you briefly speak on the correlation between weight loss and lowering blood pressure? Does lowering weight contribute to a decreased blood pressure, or can someone with a standard BMI still express high hypertension?
Yeah. So I think hypertension is more correlated in the individual who has overweight or obese. But also I had to think about it that population data is a little bit different as well. But first, let me talk about overweight and obese. Yes, there are data that supports, and I unfortunately cannot recall on the top of my head in terms of weight and direct correlation, how much increase in blood pressure. But there is strong evidence that weight loss when you're overweight or obese, further weight loss can significantly decrease your blood pressure. And then personally, I do have seen these events in which patient has lost 30, 40 pounds and have noticed the blood pressure getting a lot better, and we have to slowly titrate off medications. So anecdotally, I have seen these cases directly in patient experiences. Likewise, the other thing I want to talk about is that what is considered the general population of overweight is we from other data that suggests that in patients of Asian heritage or Asian descent, they may not be able to, it's not a one size fit all. The BMI of 25 may not be considered a one size fit all for other individuals from other countries. So albeit you might be considered BMI of 25 and that's considered normal in America, you might still be considered a bit overweight. So overall, I think my thought and my approach is a healthy body will help you overall. Stay healthy, try to eat right and exercise regularly.
Thank you so much, Dr. Lay and Dr. Kim, regarding all of the expert opinions that you have provided with us today. Really appreciate it. Just to wrap up our webinar for today, we always offer here at CoreKidney a great resource for everyone to please follow. Medically Speaking with Dr. Eve Glazier. She has been featured with Dr. Anjay Rastogi on countless occasions, and this is a great resource for everybody to connect with and engage with as well. Furthermore, if you would like to learn more about kidney disease awareness, or would you like to get an appointment with Dr. Kim or Dr. Lay, please reach out to us at Core Kidney. We're more than happy to refer you to them both. And finally, thank you everyone for joining us today. We really appreciate it. And please tune in for our next chat as well. Thank you so much, everyone.